some of the patients, what is the time frame that the patient can recover from the ICU? Obviously, if patients requiring a lot of sedation with intubation and we don't know, they take longer to wake up. When do you decide to call a neurologist to help with those cases?
So, quite frankly, there has been a lot of variability as far as length of sedation, and the other problem is that those patients require a lot of times paralytics to treat if they are prone, and we are using a lot of alternative means for sedation. We call it vitamin S. A lot of patients are on Seroquel. A lot of patients, especially in the beginning of our surge here in Arizona, we use ketamine on some patients because of the lack of certain sedatives. We never truly run out of medications or ventilators, but we're getting close. So a lot of those patients that are on ventilator early, they recover fairly quickly as far as mental status. Unfortunately, patients who are sedated for multiple, even 2 or 3 weeks, and we've had instances when patient recovered respiratory-wise, even requiring tracheostomy, but after cessation of all the sedatives, for a week or 2, their mental status was not recovering. The patients had fairly typical slowing on EEG without any large strokes. I mean, those patients do undergo CT scan of the head, eventually MRI if the CT scan is unremarkable. But whenever those patients don't wake up from sedation after complete discontinuation of sedation for about 3 to 5 days, neurology is on the case. And, but some of the studies that we do before calling our neurology colleagues in, only if we cannot discern really if there's anything else reversible.
Sure. Yeah. We know that these patients, obviously, they lack oxygen, and once they lack the oxygen, they certainly, certain area of the brain do recover slowly after what we call a hit to the brain. Donc, les malades qui sont intubés et sous une sédation lourde, ils récupèrent lentement. Et parfois, ça demande une intervention de plusieurs médecins, à savoir le neurologiste. Il y a des centres qui ont aussi un neuro-rehabilitation, meaning patients that needs, after leaving the ICU, they need a lot of neuro-rehab as being they never recover right away and be on baseline. You might need to see, you might see a mental status change, slow in thinking, delirium, and that's what needs to be. One needs to be aware of those.
And the other issue is that we know from previous treatment of ARDS patients that they have psychological disability a lot of times, and that lasts weeks, if not sometimes not months, after an acute illness. Just generalized inflammation, cytokine storm, they cause brain changes. The other issue is that a lot of patients are treated with neuromuscular blocking agents with moderate to high dose steroids, and we know that unfortunately escalates the amount of critical illness, polyneuropathy and myopathy, and delays recovery.
Right. Now, have you noticed any change or any, are you leaning towards one treatment than the other as far as remdesivir or COVID plasma, or are you introducing steroids from the get-go when you intubate a patient? As I'm just going to translate this in French. Est-ce que vous avez un penchant à utiliser remdesivir ou the plasma des COVID patients that have les patients qui ont récupéré, ou bien est-ce que vous introduisez les anti-inflammatoires stéroïdiens dès le départ quand le patient est admis aux soins intensifs?
So the population that we are specifically dealing with are sicker patients. A lot of times, if the radiographic studies are consistent with COVID, patients are started on dexamethasone right away. Since we have to wait for the results of the COVID test, we cannot start remdesivir or convalescent plasma until the test results are positive. But patients who come to us, they are started on dexamethasone, empiric antibiotics, and obviously oxygen therapy. And we have been lucky to have sufficient amount of remdesivir and convalescent plasma to treat most of the patients with a combination of treatment. But that treatment is delayed until the results are positive.
Yeah, obviously including heparin, right?
Correct. So the D-dimer and also starting full dose anticoagulation, those who have at least 2 or 3 times above upper limit of normal of the dimer, and especially morbidly obese. We're dealing with a lot of morbidly obese patients, including our Native Americans, and that presents challenges.
Okay. You're silent, Michael.
Okay. I want just to add some thing about the plasma, convalescent plasma that we are using in the hospital, and the Mayo Clinic. It's the leader of the convalescent plasma, and the requirement to give the convalescent plasma لازم يكون المرض those criteria. Number 1, the PCR يكون positive. Number 2, the oxygenation should be less than 93%. The FaO2, PaO2 should be less than 300. Or the patient has critical issues. That means he has respiratory failure or organ failure. But now, in the last week, the criteria changed by Mayo Clinic, and now we accept even the patient before the test is positive. That means if you think that the patient clinically has the COVID-19, we start the convalescent plasma. My question to Dr. Stola, because you are doing also convalescent plasma in other, you have convalescent plasma patients in other hospitals. What do you think the result of those patients recovering from the COVID-19 as far as the patients that are taking the plasma or remdesivir compared to the one that are taking standard treatment?
So unfortunately, it will be very difficult to discern that, because majority of our critically ill patients receive all the above. It's only after we do analysis after the study we'll be able to objectively say whether those patients did benefit from the treatment or not. And especially if we compare it to centers that have less of an access to one or the other medication versus plasma, and make a comparison when it's adjusted for severity of the illness.
Thank you very much. Dr. Stola. Oh, you can go ahead, Dr. Dinar.
No, go ahead. I just needed to interject here. One of the people in the group has asked, can the patient be reinfected? Have you seen patient coming back to the ICU? Readmission. Est-ce qu'il y a des malades qui ont été réinfectés et arrivés aux soins intensifs une autre fois?
So it's almost impossible to prove it since a lot of those patients are still testing positive by PCR, which is very sensitive. And those patients have long persistent changes on their x-rays. So usually we don't see anything that we would suspect a reinfection. However, the reinfection with the bacterial organisms, what we also see more frequently, especially lately, is pneumothoraces or pneumomediastinum in patients who are even treated and discharged to a rehabilitation facility. They come back with shortness of breath, and we see what we call spontaneous pneumothorax. And a lot of those patients seem to develop small lung cysts after infection with COVID-19, and rupture of those cysts result in pneumothoraces, or in treatment with mechanical ventilation with increased peak and plateau airway pressures result in pneumomediastinum. But specifically reinfection, not that we can tell.
Go ahead, Sadouk.
السؤال اللي طرحته على الدكتور ستولا هو في البلازما convalescent plasma. Is there any what's the efficacy of convalescent plasma with the other hospitals that he is going to? Especially we are using the convalescent plasma in many hospitals here. So far there is no, we can't decide. He said we can't decide now because we are using the convalescent plasma, remdesivir and dexamethasone. ثلث الادويه اللي رانا نديروا فيهم دكساميتازون ورمديسيفير مع الكونفاليسنت بلازما. اتس ديفيكولت باش تعرف واذا كان هناك فعاليه في اي واحد منهم ولا لا حتى تنتهي الدراسه و do the statistic analysis بعدها تبين الامر. لحد الان فقط نستمر نديو الرمديسيفير وهو الان مش في مرحله فيز 3 وانما هو as treatment. It was confirmed authorized by the FDA. يعني ال FDA سمحت باش يستعمل الرمديسيفير بينما الكونفاليسنت بلازما مازال في طور الريسيرش. Thank you. Go ahead, Dr. Dinar.
I wanted to say also Dr. Piotr قال باللي انه ال reinfection par le même virus n'a pas été noté. Peut-être qu'il n'y a pas moyen de le noter à partir du moment que les patients qui quittent les soins intensifs ont des séquelles qui restent quand même prolongées. Donc il y a des malades qui ont des kystes au niveau pulmonaire qui s'ouvrent vers le médiastin ou bien le thorax, les plèvres, ce qui fait que ça fait une rupture et donc ils sont réadmis pour ces complications et pas pour une autre infection. I wanted to ask Dr. Sadouk, has it been, what about the hydrochloroquine and all that stuff that we heard all that noise about? Is it still being used by others or not?
First thing, the hydroxychloroquine or the chloroquine, whether with azithromycin or without azithromycin, there is too many studies that has started. The first one was started in China, and then Dr. Raoul Didier in France, although كما تعرفوا الستادي اللي دارها راؤول ديديer في France كانت study small sample, just about 20 patients, and this is not statistically significant. Number two, he checked the end point of the research اللي حوس عليها ما حوس على clinical improvement بينما شاف فقط load of the virus, the COVID virus in the nasal. So now there is at least 3 big studies, one of them in Brazil that contains 368 patients, and there is one just في مجلة Annal of Internal Medicine in the last week, being the study that double-blind with hydroxychloroquine, مجموعة طولهم hydroxychloroquine, مجموعة طولهم hydroxychloroquine with the azithromycin, and the third group, nothing. What they found, there is too much complications on the patient that took the chloroquine or hydroxychloroquine, whether with or without azithromycin, but there is no improvement. الآن لهذا في تضارب الآن هل يعطى أم غير يعطى. في الولايات المتحدة الآن ال FDA منعت نهائيا إعطاء الهيدروكسيكلوروكين، وكذلك في معظم دول العالم. والآن منظمة الصحة العالمية the World Health Organization and the NIH في الولايات المتحدة they are doing the biggest study to be sure if it is working or not. But the summary is now most of the research until now they didn't find any improvement with the coronavirus, whether early or late or in prevention for the COVID-19. So it's still a question mark. Did I answer the question?
Okay. Sure, yeah.
We have to add just last question and then we move on. If there is any time, then we'll go for the other questions. Go, Hakim.
Okay. The question is either for both or anyone can pick up an answer. If is the immunity from COVID-19, is it permanent or is it a temporary immunity? Does it protect you from reinfection? And what do you expect with the flu virus coming soon by the months of the falls and winter? Will you are you expecting any cross communication between the two viruses or added burden of the disease on COVID patients? Pour répéter ça, est-ce que l'immunité qui est acquise après l'infection au coronavirus est permanente ou elle est temporaire? Est-elle protective? Et est-ce que bientôt on va entrer en hiver, l'automne et l'hiver, il va y avoir le virus de la grippe? Est-ce qu'il va y avoir une communication entre les deux? Parce que que le virus peut communiquer une certaine virulence, ou bien va-t-il ajouter une lourdeur sur le COVID-19?
Dr. Dinar, I can answer this question, and Dr. Stola, if you can add anything after that. Number one, we don't know that the immunity lasts for how long, because now we have at least almost 9 months since the COVID started, and we don't know if it protects or not. Definitely we know, نعرفوا definitely 100% that المرض لما يصاب بالكوفيد 19 راح يكون ليزونتي كور وتم قياس ليزونتي كور، ولهذا لما نديروا الان الكونفاليسنت بلازما نحن نحيو ليزونتي كور من المرض اللي ارتاح، نقيسوا ليزونتي كور شحال لازم تكون كميه كبيره. at least the list is 1/160 حتى 1/400. China they داروا study 1/400. هنا راه اي واحد نقيسوا لو طو ديزونتي كور، لو طو ديزونتي كور في الدم اذا كانت more than 1/160 we expect that it help for the immunity. But for how long, we don't know. That's why the vaccine that will be produced, we don't know for how long it protects the patient, and we don't know even if it protects or not. الدليل على ذلك انه المرض اللي حد الان رانا نجريو عليهم الابحاث في البلازما رانا نعطيو لهم لي زونتيكور تاع اللي كونوهم المرضى الاخرين، وفي بعض المرات ما ينفعوا اي شيء، وبالتالي we don't know for how long, we don't know if 100% protect or not. But until now there is no documented any patient، لا يوجد اي مريض منذ بدأ الكوفيد 19 أنه أصيب بالكوفيد 19 ثم أصيب مرة ثانية، ما كانش حتى مريض. نعم موجود يكونوا لي زونتيكور، وعلى هذا نديروا التيست موجود باش يعرف الإنسان قد مرض ولا مرض. هل تحمي أو ما تحميش؟ لسه ما زال الوقت قدام حتى نعرفوا هذا الشيء.
Now, in regards to influenza and approaching influenza season, there is some data from southern hemisphere from Australia that the spread of influenza has been significantly decreased. You have to remember that at least in majority of countries that somewhat enforce masking and wearing a regular surgical or cloth masks, this is what we use normally even in the hospital when entering a room of patient with influenza. So it's expected that the spread of influenza not only in healthcare facilities but in the community will be significantly decreased. The cases described in Southern Hemisphere are way less frequent, and the social distancing and masking may further decrease that. Initially expected double hit in the fall from coronavirus and influenza may not be as great, but unfortunately, that's the time will tell.